By definition, aortic dissection is a tear in the aortic intima, and that enables the blood to force its way between the other layers of the vessel wall, forming an intimal flap that divides the aorta into a true and false lumen. There is a tear in the aortic intima, causing the presence of an intimal flap, which divides the aortic lumen into a true and false lumen. Here is a diagram showing the dissecting aortic lumen with a true lumen and the false lumen, and in between there is an intimal flap that contains a tear and is considered the point of entry of the blood from the true lumen into the false lumen. The pressure of the pulsatile blood within the aortic wall after dissection leading to the extension of the dissection. The dissecting flap may be localized or may be spiral across the entire length of the aorta. Arterial pressure and the shear forces may lead to further tears into the intimal flap. Distension of the false lumen with the blood causes the intimal flap to compress the true lumen, narrowing its caliper and distorting the shape and leading to the malperfusion. Here is a diagram showing the difference between the normal aortic lumen and the aortic aneurysm with a dilated lumen exceeding that of the normal, and the aortic dissection which with its characteristic flap and the false lumen that may contain the blood clots, and the true lumen that may be compressed by the false lumen containing the blood clots. For clinical classification of the aortic dissection, Stanford is one of the most common classification used for the clinical classification of the dissection, which is more widely used, and it classifies the dissection that involve the ascending aorta into type A, regardless of the site of the primary intimal tear, and all the other dissection are classified as type B. Type A dissection involves the ascending aorta with or without extension into the descending aorta, and the Stanford type B dissection are those that do not involve the ascending aorta. The symptoms of the aortic dissection can be variable, and this emphasizes the importance of the high index of suspicion. Pain is the most common presenting symptom, and it occurs in approximately 95% of the patient, and it is usually described as sudden in onset and being at its maximum intensity from the beginning at its inception. Those with painless dissection are often found to have chronic dissection, significant neurological symptoms, or heart failure dominating their presentation. Suspected aortic dissection should be suspected clinically from the history and physical examination when a patient presents with the severe, sharp, or tearing, often migratory anterior chest pain in case of the ascending aortic dissection, or posterior chest pain or back pain. Acute aortic dissection is considered highly lethal if not recognized and treated aggressively, so it is an important cardiac emergency. Patient may have a cardiac arrest from the hemopericardium or due to rupture. Approximately 20% of the patients with the acute aortic dissection die before reaching the hospital. Aortic dissection is a more common problem than the ruptured abdominal aortic aneurysm, and type B patients are typically 10 years older than the type A patient, with a peak incidence between 60 and 70 years for the type B patient and 50 to 60 years for the type A patient. Hypertension is present in approximately 75% of the type B patient, and which is considered an important risk factor to search for. Risk factors for the aortic dissection include the increased age and the male sex, the history of smoking, history of the pre-existing aortic diseases or the aortic valve disease, and the family history of aortic diseases, and the history of the cardiac surgery, history of direct blunt trauma, or the use of the intravenous drugs. chronic aortic dissection are those surviving more than 2 weeks, and there are two important independent risk factors that are most often identified in patients with type B dissections, which are the hypertension and age. Aortic dissection high-risk clinical features include the severe tearing or ripping chest pain and the pulse deficit, the presence of the hypotension, the new murmur of the aortic regurgitation. Usually, the diastolic murmur in a patient with the newly onset chest pain should raise the suspicion of the aortic dissection, and the chest X-ray with a widened mediastinum and the abrupt onset of the chest pain. Mortality and morbidity differ significantly from type A and type B dissection, and they depend on the type of the therapy and the medical comorbidities of the patient. But to know that type A is more immediately life-threatening problem than type B dissections. Type A aortic dissection patients may die from pericardial tamponade due to the hemopericardium. They may present with a severe hypotension, or they may end with a cardiac arrest, or the rupture of the aneurysm itself and the aortic valve dysfunction. An important diagnostic feature in the type A aortic dissection is the diastolic murmur of the aortic regurgitation, which may accompany the acute chest pain, should make the one suspect the aortic dissection. The mechanism of the acute aortic regurgitation following the dissection may be due to the incomplete coaptation of the aortic leaflet because of the concurrent dilatation of the aortic root and the annulus, or due to the aortic leaflet prolapse because of the dissection flap into the aortic leaflets, or the circumferential dehiscing intimal flap may prolapse into the left ventricular outflow tract during the diastole and interfere with the valve coaptation. Another important cause of the death is the malperfusion of the coronary artery. Involvement of the dissection flap into the ostium of the coronary artery occurs in 1 to 2% of the patient, and usually involves the right coronary artery and leads to the acute myocardial infarction. Patients who present with the syncope are more likely to have the type A dissection than the type B dissection. Syncope is associated with cardiac tamponade, stroke, and death. So, type B dissection is less dangerous than type A dissection. However, patients with the type B dissection who have complications such as the limb ischemia, renal failure, or the visceral ischemia have a 2-day mortality up 20% and may prompt the need for the surgical intervention and leading to the instability of the patient being critical. If the dissection involves the ascending aorta, it is a surgical emergency. Any delay in the treatment may lead to the frank aortic rupture or the acute aortic regurgitation, the cardiac tamponade, and the death. Distal aortic dissection, on the other hand, is treated medically rather than surgically. There are different types of the acute aortic syndromes. Number 1 is the aortic dissection, which is a tear into the intimal layer leading to the formation of the false lumen in the medial layer of the aorta and potentially propagating antegrade or retrograde into the aortic wall. Second is the aortic rupture, which is a full wall thickness tear leading to the cardiac tamponade. Among the other complications, the rupture is frequently preceded by dissection, or the intramural hematoma, which is a thrombosis of the false lumen secondary to dissection, or the rupture of the vasa vasorum leading to the intramural hemorrhage. Fourth is the penetrating atherosclerotic ulcer leading to the infiltration of the media by an atherosclerotic plaque. The rate of the rupture is very high. This diagram showing the several types of the acute aortic syndromes, either aortic dissection or the aortic intramural hematoma or the penetrating atherosclerotic ulcer. Chest radiographs are usually non-specific, but they may demonstrate a widened mediastinum in the patient of the aortic dissection. Echocardiography is of the most important diagnostic tools. It is readily available in most hospitals and non-invasive and quick to perform and allows the full examination bedside. The transthoracic echocardiography is a reasonably accurate screening tool for the ascending aortic dissection, type A dissection. Findings include a dilated aorta with a linear mobile signal in the lumen representing the dissection flap. The transesophageal echo, on the other hand, is a diagnostic procedure of the choice. Its sensitivity and specificity are similar to those of the computed tomography, and it is being portable and easy to use. The left ventricular and the valvular functions can be defined during the TE studies. Here is the echo from two patients. The first shows a dilated ascending aorta with a circumferential aortic dissection flap that prolapses inside the left ventricular outflow tract. The aortic root is severely dilated, the annulus is dilated, and the ascending aorta shows significant dilatation. Figure P shows a dilated ascending aorta, but the annulus is not so much dilated and there is no flap, no dissection. Echocardiography of a patient with acute aortic dissection type A with an intimal flap inside the dilated ascending aorta and prolapsing inside the aortic valve. The flap just begins distal to the aortic valve. In the figure P, the flap divides the aortic lumen into a false and true lumen. In the figure C, there is a severe aortic regurgitation complicating the aortic dissection, most probably due to the prolapsing flap inside the aortic valve. Computed tomography, or the CT, is the most important diagnostic tool. It is highly accurate for the diagnosis of the aortic dissection, but it requires an intravenous contrast, and without the contrast enhancement, the aortic dissection may go undetected. It is important for identifying the thrombus into the false lumen. It is the most reliable diagnostic tool, and it is available in most of the emergency rooms and can be performed rapidly. It demonstrates the site, the location, and the size and the extent of the aortic aneurysm, and it is a very good guide for the surgical approach to the aneurysm. Here is the CT of a patient with acute aortic dissection and showing the flap separating the lumen into a false lumen and the true lumen. The false lumen is bigger than the true lumen and may contain a thrombus. Magnetic resonance imaging, or the MRI, it is an accurate diagnostic tool for the detecting of the acute aortic syndromes. It produces a high resolution aortic images with the 3D resolution, but it is rarely performed in the emergency setting because of the several limitations, mainly in patients with certain implantable devices. Here is the MRI of a patient with the aortic dissection, showing the separation of the aortic lumen into a true false lumen and the extension of the flap being spiral. Management and treatment of the aortic dissection. Whether acute aortic dissection is type A or type B, medical therapy to control the pain and hypertension is essential in all the patients. And beta blockers have the desired effect of reducing the blood pressure and the heart rate. Systolic blood pressure should be controlled between 100 and 120 mm mercury, and the heart rate should be approximately 60 beats per minute. Vasodilators such as the calcium channel blockers or the nitroglycerin are useful in reducing the hypertension in the emergent situation. In patients with type A aortic dissection, surgical treatment is the gold standard. In most patients with the type B aortic dissection, medical therapy including the analgesia, the antihypertensive drugs, and the bed rest is performed. But complicated type B aortic dissection is an indication for the urgent surgery. This is an algorithm for the treatment and management of a patient with a chest pain. After history and physical examination and the routine blood test, the troponin, the D-dimer, the ECG, and the X-ray, we can classify the patients whether they have a pulmonary embolism, aortic dissection, or the acute coronary syndrome. Patients with the aortic dissection, they are further classified according to the Stanford classification, whether there are type A or type B. Type A patients should have an open surgery, but type B, they either uncomplicated or complicated patients. The uncomplicated type B aortic dissection, medical treatment with or without endovascular treatment في subacute phase is the choice, but the complicated type B aortic dissection may require endovascular treatment and the urgent surgery.